Good day, these great surgeons. Miss you all a lot, and together we will crack the GIT, abdominal wall, and hepatobiliary, as well as a colorectal chapter in a minute session together. I want to make you sure that those chapters are overlapping with many chapters, even the trauma, anatomy, pediatrics, and their own chapters entity. They are all at a whole unit. So they have a big deal in the exam. But take care. For example, the stomas, you have to take them piecemeal, and it's all about logic thinking, not about memorization. You have to understand the concept to can answer the question with ease. So no pressures at all, and don't exhaust yourself with memorization, but understand and make sure you understand everything. And hope you listen to our lecture online because it will make this easier than ever. And I've made for you a whole mock about the stomas to kill this item and make it like knife in the cheese. So together we can, with the grace of God. These beloved great surgeons, can you hear me? Let's try this
Yes, sir.
once again to make this session more productive and more fast. So regarding the features of acute appendicitis, if anyone having a profuse vomiting, it's rare in early appendicitis. So in this question, the trick is not what is typical, but what is not typical. So take care from those tricks in the exam. I have fallen in my exam in some of those questions myself. The not word. Take care. And by the way, if you want a sure sign regarding appendicitis, it will be anorexia. There will be no one have appendicitis and is willing to eat. He will be anorexic and refuse any scent of food. Clear?
Yes, sir.
So, if you are in the operating room and you are having an acute abdomen case, you are suspecting appendicitis, and you entered the room and found it without acute appendix, what would you do? Did you hear the question? Again, you are the main surgeon and you entered the operating room suspecting acute appendicitis and you found the appendix is not inflamed. What would you do? Any ideas?
Sir, if it's still not inflamed, as we have already entered the cavity, we will do the appendicectomy.
That's great. I like your thinking. But before you do appendectomy, what would you do? Would you search for Meckel's, for example?
Yes, sir.
Yes, sir.
That's the word I want to hear from you. So you will search for other causes of acute abdomen. And then, of course, do appendectomy. How about if you found the Meckel diverticulum accidentally intraoperatively during any other elective operation? What would you do?
We got to go for right hemicolectomy, right, sir?
For a Meckel's,
Oh, no, 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 no.
would you do? You found the Meckel's accidentally during laparoscopic cholecystectomy, for example. Would you do Meckel's diverticulum excision? No. When would you do it? There is a criteria to do excision of the Meckel's. It's a hard question. Okay, at least you have to know that lateral hernia is the hernia containing Meckel's diverticulum. So let's revise some hernia's content. If we have the hernia sac containing the appendix, what would you call it?
Appendicectomy.
No, I mean, what is the name of the hernia that is
Amelior's hernia.
containing appendix? If you open the hernia sac and found an appendix, what you call this hernia?
Amelian hernia, whatever.
That's
forgot
great,
the name.
amnion hernia. That's great, amnion hernia. If you have both direct and indirect hernia, what is this hernia called?
W or M pattern, sir. I just forgot the name.
Pantalon hernia.
Pantron hernia, right, sir?
You know the pantalon, we all wear the pantalon. So we have two limbs. What is Spiegelian hernia?
It will occur, sir, in arcuate line.
That's great. It's
In the
adjacent
semicircular
to the
canal.
architrave.
Along the lateral border of rectus.
Rectus sheet and linea seminolaris.
That's great. Do you know what is the difference clinically between the umbilical and the para-umbilical hernia? Clinically.
Umbilical hernia through the umbilicus, but para-umbilical hernia along the right side of the umbilicus.
You want to say that the para-umbilical hernia is a defect in the linea alba, but clinically you will find it a crescentic shape.
It's a weakness in the linear.
If you found a crescent shape in the hernia, in the umbilicus, it's a para-umbilical hernia. Okay.
So, sir, para-umbilical hernia is crescent shaped or umbilical hernia is crescent shaped?
The para-umbilical will be crescent shaped. Can you see this photo? This is a para-umbilical hernia. Let's see an umbilical hernia. You will never see a crescent shape in umbilical hernia. Clear?
Yes, sir, it is.
When I write too fast, some letters go below. So let's have another beloved question. What is this case? You have a 78-year-old lady admitted for small bowel obstruction on examination.
Obturator hernia.
Obturator hernia. Yes, it's a very rare and require a genius surgeon like you to diagnose an obturator hernia. Where does it herniate from?
Sir, it herniates from obturator canal.
Posterior to the pectineal muscle.
Posterior to the pectineal, yes, sir, muscle. And because this lady is showing this sign that we call house-shaped Romberg sign, in which pain radiates to the medial side of the knee in the distribution of obturator nerve, because she has no mass, no mass in the groin, because obturator hernia does not show any mass.
You are such a perfect surgeon. Are you a general surgeon?
No, sir, I have just started preparing for MRCS.
Wow.
I am a fresh graduate.
You are such a great surgeon to be. So honored to have you
Thank
with
you,
us.
sir. Sir, actually, I am a friend of Muhammad Ali. You know him.
What?
Muhammad Ali, Dr. Muhammad Ali.
Yes,
He is your friend.
yes.
Yes, I am his best buddy.
So honored to have you. Send his greeting for me, please.
Sorry, honor is mine. Honor is mine to learn from you.
So you are so fond of hernias. How about the rector's hernia? The rector's hernia. What do you know about the rector's hernia? It was a sudden question, Faisal.
Sir, rectus hernia is that type of hernia in which a part of the small bowel, I believe, is
Root of
got
mesentery, in fact.
strangulated or in the hernia.
Hernia occur from root of mesentery.
The
Most
anti-mesenteric
commonly,
border.
yes, most commonly anti-mesenteric border is strangulated or obstructed in another hernia.
That's great. You will see in the rector's hernia that a part of the wall, and it's most usually the antimesenteric border, to be protruded through the hernia defect, not the whole lumen. It's a part of the lumen. And clinically, you will find it like a balloon, and there will be no obstruction, but there will be a severe pain because this part of the lumen might be ischemic and congested by time. So you have to be very suspicious for this type of hernia. And I have seen for myself 3 cases in
So,
my
sir,
experience. This is the rector's hernia. So it's a condition where a part of the wall of the small bowel, usually the antimesenteric border, to be strangulated within a hernia. And you have to explore for it. Clear?
yes, sir, it is clear now. Thank you, sir.
So if you have a W-shaped bowel, what you can call this hernia? W-shaped bowel?
So parietal hernia.
Middle? It's called middle hernia. Let's see a picture for it. Yes, Dr. Aisha, you are such a great surgeon. You should do much. So it's middle hernia. And clinically, why I should know the name of the middle hernia? It's not about the name, it's about the clinical applied about the middle hernia. You have 2 loops within this hernia. You have to explore both loops and make sure you don't reduce both loops. You have to explore for them, especially if they are strangulated. This is the clinical applied of the middle hernia. Clear?
Okay.
So let's have a refreshment question out of the hernia. I know when we stress on some topics, you might get some headache. So let's have a happy question. What is the Wa sign?
Hypersensation occur in the tip of the right shoulder.
Yes, Wa sign is hyperaesthesia of the tip of the right scapula. It's seen classically in acute cholecystitis. That's great. What is the Cullen sign?
Intraperitoneal hemorrhage occur, then it will be seen.
The
Yes,
Cullen sign is when there is intra-abdominal hemorrhage, mostly due to pancreatitis.
No, pancreatitis is retroperitoneal. Retroperitoneal sign.
no,
There will be gate and
that's
Yeah.
great
signs.
surgeon.
Golden sign is around the navel.
It can
Exactly.
present with pancreatitis can present with both intra or retroperitoneal bleeding. It could, and that is where we have greater nerve sign when it is retroperitoneal, and when it is
Cullen sign
intraperitoneal.
would be seen in
Cullen sign.
intraperitoneal, like ruptured abdomen, pancreatitis.
That's great from all of you. So let's make it clear. The Cullen sign is not a specific sign for pancreatitis, just like the Great Turner sign is not a specific sign for pancreatitis. No, the Cullen sign is intra-abdominal hemorrhage around the navel, while the Great Turner sign is a retroperitoneal hemorrhage sign, and most common to be found in trauma. So if you found around the navel, around your umbilicus, ecchymosis and bruises, both traumatic, you have to suspect intraperitoneal hemorrhage. Just like the Great Turner sign, when you see ecchymosis or bruises on the left flank, you have to suspect it might be a retroperitoneal hemorrhage, especially for the spleen. And the spleen is the most common to be ruptured. That's why the GIT is overlapping with trauma. So you have to be keeping all of this in mind. And always look to the pictures because it will make this clear. Clear?
Yes, sir.
Oh.
Yes, sir, it is. Thank you.
So do you know a sign of pain called Murphy sign?
Yes, sir.
Yes, sir.
Yes,
It's
sir.
specific for
Gallbladder.
Acute cholecystitis.
so you will put your hand in the right hypochondrium and ask the patient to take a deep breath. And you will find the patient in a deep pain and can't withstand your hand. This is the Murphy sign, indicating for acute cholecystitis. How about the Robsing sign? Do you know a sign called Robsing sign?
Yes, sir. We elicited in
Robin sign for
appendicitis.
acute appendicitis. But it will be absent in ventricle position.
Uh,
Robsing sign is for appendicitis. What sign do you know else for appendicitis? Obturator, for example, or SOA sign?
no, sir, we do not.
So
And McBurney point tenderness occur.
who can tell any other signs for acute appendicitis?
So McBurney point tenderness.
I like this one.
Rebound tenderness, sir. Also.
Rebound tenderness. That's great.
Also, sir, psoas sign.
So a sign or proto sign.
Okay, those are great. So let's have another habit question. Do you want a question about the stomas?
Yes, sir, please.
Are you ready?
Yes, sir.
Yes, sir.
Which type of stoma would you consider in a patient undergoing emergency operative intervention for large bowel obstruction as a result of carcinoma 5 centimeters from the
Loop
end?
colostomy. Loop colostomy, sir.
Colostomy.
Why loop colostomy?
For defunctioning.
Why not loop ileostomy?
There is well obstruction. For that reason, we'll go for loop colostomy, sir.
Obstruction is in the anal ward.
I want to
Bowel
make sure you
obstruction.
understand the concept. I am not stressing on you. So the loop ileostomy will be great if you are doing an anastomosis to make a relief over your anastomosis. While here in emergency, what is the fastest stoma you can do? It's the loop colostomy. In the loop colostomy, you will raise the whole bowel and just open a cut in between, not a full cut. Have you seen it before? The loop colostomy? Let's have a picture for it. This is the loop colostomy. And this is another one for the loop colostomy. So this is a temporary colostomy. Clear? So large bowel from carcinoma should be resected, stented, and defuncted. And the first two options typically, can you hear me?
Yes, sir.
There is some noise. Okay, sorry. So large tumor should be defunctioned with a loop colostomy and then formal staging undertaken prior to the definitive surgery. That's why you have taken the loop colostomy in this patient. After the definitive management with your anastomosis later on, you can do a defunctioning loop ileostomy. Clear? Hope this made it clear. Let's have another happy question and shift to our beloved our GIT questions. This is a long scenario, but I'm sure you can do it great. So esophageal squamous cell carcinoma can be managed with radical chemotherapy because radiotherapy alone is not usually curative, and segmental resection of the upper esophagus is not practiced anymore. Hope this made it clear. If we have esophageal rupture, what contrast material would you use in your investigation?
Water soluble.
That's a great, like
Gastrography.
such a great surgeons you are all. Those are the most common questions that come in the exam. You know already the idea, but don't confuse yourself with the long scenarios. So another happy question for you. If we have a 32-year-old man with a small painful right scrotum after being kicked in the groin area, there is a painful swelling in the right scrotum, and the underlying testis can be easily palpated, in severe pain. What is the best course of action? Would you do a testicular ultrasound, or you do orchidectomy or scrotal exploration, or just testicular aspiration? What you do?
Scrotal exploration.
Amazing. It's a scrotal exploration. I know this question, many of you have memorized it, and I know in our country, we might do a testicular ultrasound instead of exploration as a first initial action. But here, the best course of action, according to the UK, will be scrotal exploration because they trust the surgeons, they trust the doctors more than our countries. I don't know Yeah, at least in my country, we will do ultrasound to document this and the duplex as well. What you do in your country? Do you do exploration without the ultrasound or duplex? Apparently, no one does it. So it might be my only country. So in my country, we do testicular ultrasound and duplex for documentation of this situation, but as fast as possible in our hospital and institute. But this is according to the UK is not appreciated because it will not change the decision because we have acute hematocele after trauma that might have a torsion testis below and time equal testis, time equal viability of the test. That's why you have to do an urgent scrotal exploration. After you do a scrotal exploration and you do detorsion and evacuation of the hematocele, what would you do for the other testis? Fixation. That's a great, Dr. Aisha. That's a great. You will do fixation. So if you have a child, he is 3 months old and came to you with a trans-illumination test positive in his scrotum. What is this swelling?
Hydrocele.
Hydrocele.
Hydrocele. What would you do it for a 3-month-old boy? You will do
Go for ligation.
Sir,
Lig-
PPP.
just
ligation
follow
of the
up.
petrous vaginalis.
Patent process vaginalis ligation. Angular
If it's
approach.
just a hydrocele in a 3-month-old baby, you will just do follow-up. Follow-up up to 1 year. After 1 year, you can do the hydrocele by scrotal approach or inguinal approach.
Inguinal approach.
Inguinal.
That's great. Inguinal approach. How about in an adult, you have a hydrocele? How would you do
Lords and Jabula
Jabole procedure.
Jabolio large procedure in scrotal approach.
scrotal approach? That's what I'm searching for. Such a great surgeon you are. So hydrocele are managed differently in children where the underlying pathology is a patent processus vaginalis, and therefore an inguinal approach is used in children. In adults, a scrotal approach is preferred and the hydrocele sac excised and replicated, most commonly by the Jepuli procedure. That's a great. How about epididymal cyst? Can be excised using which approach? Scrotal approach. That's great. How about a torsion testis? You will do it inguinal approach or scrotal approach? It's a funny question. Scrotal approach, of course. Can we do the varicocele laparoscopically? Varicocele? Yeah. Varicocele can be done eye approach for varicocele. It will be a long way. Yes. Oh, it's yes, not eye. Okay. Funny autocorrection. So, regarding the hernia, for a bilateral inguinal hernia, would you do it surgical approach or laparoscopic approach?
Laparoscopic approach.
Laparoscopic approach. That's great. How about we have acute cholecystitis? You will do it open approach or laparoscopic approach?
Laparoscopic approach.
Laparoscopic.
That's great. How about undescended testis? You will do it surgical approach in a child or laparoscopic approach? Undescended testis in a child,
Surgical.
laparoscopic or inguinal? Why I can't hear anybody? It must be the internet, right? Laparoscopic or surgical for undescended testes?
Surgical.
Laparoscopic, sir.
Wow, we have a fight here. So it's laparoscopic. Let's make it clear. So I hope now we have compiled a laparoscopic approach indications in bilateral inguinal hernia, in acute cholecystitis, in undescended testis in children, right? Even the hiatus hernia, by the way, now it's laparoscopic. It's the gold standard. Clear? I want to hear clear.
Yes, sir. Clear.
Thank you. How about a testicular tumor? It will be excised via inguinal approach or testicular scrotal approach.
Inguinal approach.
Why would you do it?
Inguinal approach, sir.
Because we have to cover all the lymph nodes.
That's great. To prevent metastasis, because scrotum has a different inguinal lymph node spread than the testicular lymph node. The testicular lymph node it drains into the para-aortic.
The
Aortic lymph.
Para-aortic
horizontal
lymph nodes, sir. So testicular lymph nodes, the drain in para-aortic lymph nodes.
Yes, yes. Testis and ovary, para-aortic.
Such a great surgeon, all of you. So let's have another happy question, short question. Here you go. So he's telling you about a 20-year-old male who had a mild painful swelling in his right scrotum. He also complains of abdominal pain, and clinically he is found to have a swollen right testis apart from supraclavicular lymph node. What is the supraclavicular lymph node named? Verkaus.
Varkaus node.
Verkaus, yes, Dr. Nasrat, you are such a great surgeon. And no obvious other lymph nodes. So this 20-year-old male with the swelling in his right scrotum, what type of tumors might be suspected?
Teratoma.
Teratoma or seminoma?
Teratoma, sir.
Teratoma, he's a toddler, he is a young. After the age of 30, he would be more likely to be seminoma.
Seminoma.
Seminoma would be senile. That's great. Thank you, Dr. Strange. Such a great surgeon. So here he is asking you about a simple idea you know about the orchidectomy via which approach? Via inguinal approach. And we talked about it. So this patient is more likely to have a teratoma that metastasized to the supraclavicular lymph node, and there is a suspicion of a spread via the para-aortic lymph node due to the abdominal pain, and he will need orchidectomy and combination of chemotherapy. And there is no rule for orchidectomy for the scrotal approach in malignancy. Clear?
Yes, sir.
So we will start another meeting because this meeting has ended already. We have such 5 minutes. We can take another question before starting another meeting. Does this maneuver more likely than just typing? Right?
Yes, sir. It's more interactive.
So,
Zoom call is good, sir. Zoom call combined with Telegram, it will, allow us to interact more with each other.
thank you. So happy it found you happy. So let's have this question. We have a 76-year-old male presented with 5-week history of progressive dysphagia in the upper GI endoscopy performed, and the surgeon noticed a change compatible with the Barrett esophagus. Is a Barrett a cancer in itself?
No, it's precancerous.
That's great.
But it's
And
metaplasia, sir.
its a sign in the X-ray will be
Sir,
it will be managed surgically or medically, the Barrett itself.
Barrett will be medically, I think.
That's great. Barrett, it's
Surgically and medical both.
But now he is asking you that the esophagus is filled with food debris and can be cleared, and the endoscopic encounter a resistance. So it's not a precancerous anymore. It's a clear
Yes.
adenocarcinoma. Clear, right?
Yes.
And we discussed what to do with this adenocarcinoma before. And it will be presenting with progressive dysphagia and have GERD or Barrett esophagus. And you will find here, he made it clear. He is asking you that the endoscopy encounters a resistance. This is not Barrett. It have changed to adenocarcinoma already. What is a hiatus hernia? Is anyone familiar with the hiatus hernia?
Sir, hiatus hernia occurs when part of stomach slides through the esophageal opening in the diaphragm.
Yes, that's great. And how would you manage it? Laparoscopically, it will be done. What is the name of the operation?
Nissen fundoplication.
That's a great Nissen fundoplication. Let's have this question to make sure you understand all about the testicular area. We have a 28-year-old male present with a pain testis scrotum began 10 hours previously and has worsened during the time. In examination, he is feverish, pyrexia, and the testis is swollen and tender. And there is association with hydrocele. What is this diagnosis?
Epididymoarthritis.
Why it's not torsion?
Because he has fever and signs of inflammation.
That's great. Such a great surgeon you are, Dr. Nasrat. Is there any examination to make sure it's acute epidermal orchitis, it's not a torsion testis?
Yes, if the scrotum is elevated, the pain will be relieved.
Thank you. It's called a scrotal elevation test.
Yes.
Would you like to do exploration for this patient?
No.
No, sir. Medical treatment.
Antibiotics.
That's great. You are such a great surgeon. I don't find a hard question for you. I want to find a hard question. You already are amazing. This one is hard. Take this question and we will start a new meeting because this one has ended.